Now, welcome to another episode of Talking Cancer. Today, I'd like to introduce my colleague and associate, Dr. Tomás Duraj, who will be discussing information on his recent study on a new and powerful protocol for managing glioblastoma. We think this will eventually become the standard of care for how people with glioblastoma and possibly other major cancers will be treated. So he'll be able to give you an in-depth discussion of the major findings that he has developed for managing this very deadly brain cancer.
My name is Tomás Duraj. I am a physician scientist. I am originally from the Czech Republic, and I did my medical degree in Spain, in Madrid. And then over time, I decided I wanted to expand a little bit more my understanding of cancer more from the research perspective. I was a little bit underwhelmed and disappointed with the way just the whole clinical system is in general. So I developed a PhD program also in Madrid in researching the bioenergetics of cancer metabolism. And then after my PhD, I came here to the Seyfried Lab as a postdoctoral research fellow. And we here, as you know, we investigate the bioenergetics of cancer. So in the lab, I sort of wear two hats. For one, from my translational kind of background, I'm trying to understand a little bit more, to expand and to give more kind of practical background on the practical applications of ketogenic metabolic therapy for cancer management. And you will be able to see a little bit more in the recently published paper that kind of outlines the research framework or the toolkit of interventions, of tools, of therapies that can be all synergistically included to treat cancer. This is specifically for GBM, but could be applied to other cancers as well. And then I am also a basic researcher, so I do here in the lab also culture work and preclinical work with animal models, trying to find the best combinations and therapies to treat cancer. And one of my passions is try to understand cancer bioenergetics. So what keeps cancers alive, what sources of energy they can use, what metabolites and fuels they can use to stay alive and grow. And that's kind of the foundation that we have to build on the most fundamental understanding is like physics, on what we know about the physical reality of cancer cells, what they need in vivo systems, so in like a little bit more complex in mouse models, animal models, and then bringing that to the clinic. I think one of the problems that we have here is that within the field, this terminology is not very standardized. So you will see that ketogenic diets, for example, are applied across different fields in research and in the clinic. You have them for type 2 diabetes, type 1 diabetes. You have them for epilepsy, of course. That's the classical application that they had. You have them for neuropsychiatric diseases, neuroprogressive diseases, and of course for obesity, which is kind of the more common or known within the population. People use ketogenic diets for weight loss to manage weight, and within each field, the kind of the characteristics that you would find in the ketogenic diet are different. So when we're going to talk about ketogenic metabolic therapy in cancer, this has a very specific definition, and in the paper you will be able to see I try to divide it into dietary ketogenic metabolic therapy and pharmacological ketogenic metabolic therapy. The dietary ketogenic metabolic therapy I define as a sine qua non. This means as a basic essential requirement that you would need for the subsequent therapies that you would posit for the management of cancer. So, and these two come together. So this is an interaction between a diet and drugs. And so within dietary ketogenic metabolic therapy, you have different tools. And this is another thing that we often get associated with ketogenic diets. And there is nothing particularly special about the diet itself. What we feel is meaningful is that the diet induces a metabolic state in the body that basically mimics fasting. So the diet is a way to maintain fasting long term without, of course, extreme caloric restriction. And I like the terminology that, for example, Dr. Dominic D'Agostino uses about the ketogenic diet. He calls it a prescription strength diet. So this is a diet that has a set of objective biological criteria that you are meaning to achieve. So not every ketogenic diet is the same, especially for cancer management. As I said, in different fields, the diet itself might have different characteristics. So within dietary ketogenic metabolic therapy, as I said, you have different tools. Therapeutic ketogenic diet is one. Of course, fasting is the most effective, maximal way to mimic fasting is water-only fasting. But in principle, you could also use drugs to try to achieve the same results. And this is one of the things that the field and our fellow researchers at different research groups are trying to do is say, well, the diet is so complicated and it's hard to have people adhere that you would rather use drugs. Some people have used metformin, for example. This is a mild gluconeogenesis inhibitor. Basically inhibits the production of glucose from the liver, and this reduces glucose in the blood and puts some metabolic stress on the tumor cells. It's not that powerful, but it is a tool that can be used. SGLT2 inhibitors is another way to reduce insulin and to reduce glucose. These are drugs that inhibit the renal reabsorption of glucose. So basically, glucose is excreted in the urine. And other people have proposed, for example, cancer dialysis. So this would be trying to deplete the glucose from the blood with an extra corporeal system, and then infuse ketone bodies. Unfortunately, therapeutic ketosis or therapeutic ketogenic diets and fasting and caloric restriction are not. It's not only the change in the glucose and the ketones. It is also these are endogenous processes that change thousands of gene expression profiles and metabolic pathways that cannot be you cannot kind of hack it using drugs, unfortunately. If there was a way to just use a single drug or single intervention to achieve all the benefits that we see from the data that ketogenic diets and fasting and cyclical caloric restriction can have, then of course it would be much easier to propose this. But unfortunately, as I said, this is an endogenous process that can only be achieved using the therapeutic ketosis. So, as I said, we have an umbrella term of ketogenic metabolic therapy. Within this, we have dietary ketogenic metabolic therapy and pharmacological ketogenic metabolic therapy. And within the dietary ketogenic metabolic therapy, we would have different tools. And one of those tools is a ketogenic diet. But as I said, there is the caloric restriction itself, there is fasting mimicking diets, there is a Paleolithic ketogenic diet, a Mediterranean ketogenic diet, slightly more complicated to implement, but still possible, a plant-based ketogenic diet. These could be used. These could all be used cyclically to try to achieve this mimicking of the fasting metabolism that is the ultimate goal, the objective biological goal of ketogenic metabolic therapy. So with the ketogenic diet itself, the objective that we are trying to achieve is to lower our blood glucose. So this is glycemia. So it's a stable, lower than baseline level of glycemia. And of course, there's a demand-driven proportional increase in ketonemia, in ketone body utilization by the body. And this is this metabolic shift towards using fat-derived fuels for energy production. So this is using fatty acids and ketone bodies to supply as a primary contribution to the energetic and the biosynthetic and all the TCA cycle metabolism and oxidative phosphorylation of our body. We are trying to shift away from the use of glucose as our primary fuel to increase the reliance upon these oxidative fat-derived metabolites, which are, as I said, fatty acids and ketone bodies. There's 3 ketone bodies. There is beta-hydroxybutyrate, acetoacetate, and acetone. Beta-hydroxybutyrate is the primary ketone body. So this is the shift. We are with therapeutic ketosis. We are trying to reduce our glycemia and increase our ketonemia. This can be measured in the glucose ketone index, the GKI. Now, as you can imagine, so the glucose ketone index is just a ratio between the glucose that you can measure in a finger prick and a ketone measurement, which is usually beta-hydroxybutyrate. And so you just make the ratio, the division between these two, and you get a value. We usually say a value under 2, GKI under 2 is going in the right direction, and under 1 or below, it would be the optimal level. Now, but you can imagine, for example, and these need to be measured in the same unit of measurement. So glucose is usually in millimolar, and ketones are also in millimolar. You can have glucose also in milligrams per deciliter, and you would need to convert these to millimolar, because you will see that most of the measurement devices of ketones express the measurement in millimolar. So let's say you have 4 millimolar of glucose and 2 millimolar of ketones, of BHB. This would give you, if you divide 4 between 2, this would give you a GKI of 2. If you have 3.5 millimolar of glucose and 3.5 millimolar of ketones, this would give you a GKI of 1. But you could also have 4 millimolar or even 5 millimolar of glucose and 5 millimolar of ketones, and this would also give you a GKI of 1. Even with a relatively normal or high glucose, the normal level of glucose would be around 5 millimolar if you are not following a ketogenic diet. So this is just to say that the absolute levels of glucose are also important, and you would typically try to aim for as low as possible levels of absolute levels of glycemia, of glucose. With the caveat, and I see a lot of patients being a little bit confused about this and putting, I would say, perhaps too much emphasis of trying to push the glucose as low as possible. The glucose levels, of course, will be variable, and different stressors can have an impact on these. Lack of sleep, exercise will increase glucose levels, and this is a good increase. Of course, stress, many things, even excess protein can affect the baseline glucose levels a little bit. But this does not mean that you have to freak out and try to reduce them as much as you can. This is just, you are trying to keep your GKI in general and the glucose levels and the ketone levels, glucose as low as possible, ketone levels intermediate or high, depending on what your requirements of energy in the body are, to mimic chronically, to mimic this state of fasting metabolism. So as I said, I think people often give a lot of kind of emphasis on the GKI, but you should not try to hack it. For example, if you could even have a low GKI following a standard diet. If you took some exogenous ketones, then your glucose would be still normal to high, and you could have elevated ketones. But this single measurement of GKI wouldn't mean that you are in ketosis. Technically you would have ketone bodies circulating in the body, but this is not the metabolic state that you are trying to achieve with therapeutic ketosis, therapeutic ketogenic diets, or dietary ketogenic metabolic therapy. You are trying to shift your whole body into a more kind of inhospitable environment for the tumor to grow. You are trying to reduce the resources and the nutrients that would be available for the tumor. And the GKI is simply a proxy indicator that you are moving into the right direction. Of course, ideally, we would be able to measure, insulin signaling should be down, the growth signaling in general should be down, mTOR signaling should be down, AMPK should be upregulated, autophagy should be upregulated, inflammation should be lower. All these things, ideally, we would be able to measure. Some of these things can be measured in a single point, blood analysis, blood work. But what you are trying with the GKI is to sample as often as possible. Ideally, we would use continuous glucose monitors or continuous ketone monitors, at least in the beginning, to get an idea of what the patient is doing in terms of their biological adherence, and this would be an indicator. As long as it's chronically reduced and moving in the right direction, this would be the indicator that you are, because these things are associated. So the GKI is a proxy indicator for all these changes that are beneficial to try to, for sure, at least slow down tumor progression and tumor growth. Dietary ketogenic metabolic therapy, I envision it as a baseline for the subsequent therapies that has the intended effect of slowing down tumor growth. And of course, the effects will be dependent on how intensive the intervention is. If we do just a general low carbohydrate diets, perhaps we will not obtain the same effects as if we do a very strict therapeutic ketosis with intermittent fasting or long-term fasting in between. And we achieve this by, of course, lowering the glycemia. So we are restricting not only glucose from the tumor, but we are lowering many other pathways that are involved in the ability of tumor cells to grow by increasing the ecological competition between the tumor cells, which hopefully are a very small populations of cell in the body compared to the trillions and trillions of cells, of normal cells, which still compete for all the resources, the nutrients, and even the growth factors. There's a competition between tumor cells and normal cells. So it is not only the glucose levels. You could measure glucose levels at one single point, and that wouldn't give you information of what is this ecological competition between tumor cells and normal cells. Of course, one of the criticisms that we often get is that it is possible technically to implement a ketogenic diet that is either neutral or not beneficial for the treatment of cancer. I have to say, at least from the human studies that I have seen, and please, if somebody knows about any other, we are happy to hear about them. In no single human study of ketogenic diets for cancer treatments, there have been reports of like hyperprogression or accelerated tumor growth. So it's either neutral or it's beneficial. However, in animal models, due to the differences in metabolism between mice and humans, you can design a pro-tumoral ketogenic diet, or at least you could see in studies when they are ad libitum, so this means where the ketogenic diet is unrestricted, you see sometimes that the benefits are not as pronounced as the researchers would want. It's usually not an acceleration of the tumor growth, but you could have neutral effects also. And we often get these studies shown to us like, hey, you see, ketogenic diet sometimes also doesn't work. In this case, what you have usually is basically you don't have a caloric restriction effect, so the mice do not lose weight. And you see that the ketones are high, so you can have moderate to high ketonemia, but the glucose is not reduced. The glucose is also either normal or even high. So of course, if there is sufficient primary fuel, which is the glucose and the glutamine for the tumor, and you're just adding excess fuel and excess calories to the system, then of course you could have neutral effects or even acceleration of tumor growth. So this is one of the reasons why we put the emphasis on the chronic reduction of the GKI and the definition of dietary ketogenic metabolic therapy as a way to mimic fasting metabolism. If you are not mimicking fasting metabolism, then you are not implementing a therapeutic ketogenic diet. You might still implement a ketogenic diet that increases ketones but doesn't lower glucose, and maybe lose weight or maybe have improved for sure. You can have improved, insulin signaling. So for type 2 diabetes, this is a great tool without weight loss. But in general, there should be a little bit of restriction, a little bit of caloric restriction going together with the ketogenic diet. So that's one goal. And the second goal is to prime the body towards the drug therapy. So this can be standard of care, and we know therapeutic ketogenic diets, dietary ketogenic metabolic therapy synergizes well with standard of care across different tumors. Special case for GBM, we would need to go into more detail what parts of standard of care we feel are more or less indicated for glioblastoma as a special case. But in general, across most of the studies, the human clinical studies that have been done, have been in synergy with standard of care. So for standard of care, these are, chemotherapy is technically a drug, but the point is to use metabolic inhibitors that would be directed at substrate level phosphorylation fuels. This is glucose and glutamine, and these are the primary fuels that cancer cells are dependent on. And to be able to inhibit glycolysis and glutaminolysis, you need to make this shift in your normal cells to these alternative fuel sources, which are fatty acids and ketone bodies. If you didn't make this shift, you could still target, you can target like glycolysis or glutaminolysis, glucose and glutamine metabolism, anytime you want, but the threshold of safety and sensitivity of your normal cells would be also very narrow. You could still kill tumor cells by inhibiting glutamine metabolism without any adaptation with dietary ketogenic metabolic therapy, without switching your metabolism of your normal cells, but you would have more effect on your normal cells' energy metabolism if you don't do this shift. So the purpose is both to slow down tumor growth, but also to prime the normal cells to withstand and to be less sensitive to the drug therapies. And within the pharmacological ketogenic metabolic therapy, so our main idea would be to use metabolic inhibitors against glucose and glutamine metabolism, but also we want to bring in many repurposed drugs which have shown some efficacy for the treatment of cancer, to kind of make it a little bit more democratic, to use tools that are already available, that are generic drugs that can be used by any practicing physician. We would also want to use systemic therapy. So this would be, for example, hyperbaric oxygen therapy or hypothermia, or even IV vitamin C, which is like a systemic redox balance therapy. And together, of course, with adjusted or adapted standard of care therapy. So we have our chemotherapy, our radiation therapy, our immunotherapies. And all these together, as you can imagine, brings a lot of complexity to how to best design trials to test all these things together, because the standard clinical trials are usually testing one single variable. So you would test one single intervention. And unfortunately, so we know from clinical trials that most of these are safe and feasible. We have trials of ketogenic diet alone with standard of care, and they synergize well. We have, of course, many trials of standard of care. We have trials of repurposed drugs individually that show some promise, of hyperbaric oxygen individually show some promise, and of metabolic inhibitors against glycolysis and glutaminolysis. For example, DON or DON prodrugs. DON is 6-deazoxy-5-oxyl-leucine, which is a drug to inhibit glutamine metabolism. We also have these trials ongoing, and different research groups and different companies are following this path. But there is little incentive, financial incentive, and intellectual property landscape incentives to combine all these together. And we know this combination, likely for metabolism, which is a special case, will be necessary to achieve the optimal results. So we want diet drug therapies using this shift in metabolism, using the ketogenic diets, and pair it with drugs to target specifically metabolism, not other pathways, metabolism. And after this, as a primary primary therapeutic modality, then we would add other therapies to build upon this foundation. And this is kind of the next frontier, which is a little bit complex in terms of how to best design these studies, but I feel they can be done. So this would be a question more on the different levels of evidence that we would have for these approaches, both dietary ketogenic metabolic therapy and pharmacological ketogenic metabolic therapy. I think this question depends a lot on the specific definition. So I hate to be so emphatic on proper definitions, but if we are talking about actual proper diet drug ketogenic metabolic therapy, the amount of trials that we would consider optimal is not as high. So we have a lot of course, preclinical work. We have work from the laboratory and from animal models, and also some pilot clinical trials that try to combine diet and drug. And we have, as I said, independent trials for many of these modalities. So we have independent trials for metabolic inhibitors. We have independent trials for diet with, for example, chemotherapy or different modalities. But what we are lacking is these combinatory trials that would put it all together. However, for what is the clinical trials of ketogenic diets, I feel at this point we have enough evidence for sure for safety and feasibility and some signal of promising efficacy. The problem is I wouldn't define these trials as dietary ketogenic metabolic therapy. I would define them as trials of a general, as least invasive and least kind of difficult to do diet as possible that you would bring into the clinic. And if you are picking patients randomly, you are trying to be as flexible with them as possible. So many times, unfortunately, these trials have, I wouldn't say it's a failure of implementation, but it is a failure of measurement. Unfortunately, most of these trials have not used real-time, and this technology wasn't even available at some of these points, real-time monitoring of glycemia and ketonemia, of glucose and ketones, for us to be able to say whether actually the patients successfully, chronically were in a state where the tumor growth would be most likely inhibited. So, and I don't want to complain, because I understand, and from my personal clinical experiences, it is very difficult sometimes to implement all these dietary changes and to bring in all the treatments. But so there has been over 20 clinical trials or clinical studies, I should say, for ketogenic diets in GBM, for example, in glioblastoma, and there's over 60 clinical trials that are ongoing for ketogenic diets in different solid malignancies, different tumors, but very rarely they include proper measurement of the GKI, the glucose ketone index, that we would consider as very important to give us an indication that the patients actually were able to implement everything properly. I am aware of one trial of Professor Gary Middleton in the UK, this Keto Lung trial, for example, where we reviewed their grant application, so we recommended for them to use continuous glucose monitors. So in this trial, which is ongoing, their idea will be to use continuous measurement of glucose, and then twice a day finger prick of the ketones, and try to ensure that the patients were actually in ketosis. If you look in detail at most of the published clinical trials, to my knowledge, not a single one of them has included sufficiently detailed measurement of glucose and ketones to be able to say, not in a group average, but in an individual patient, to correlate that this patient, for example, was extremely compliant, not only in the dietary part, but also in the biological part. So biological compliance, that the diet is actually having the effects that it should have, and then correlate this with the outcome that you would see. Some of them do try to measure, for example, at least once a day, but I would still consider that with the new technologies that we have as insufficient to get really an idea. Yeah, if you measure in the morning and you are in deep ketosis, and then you have breakfast and you are for the next 12 hours, you are outside ketosis, I don't think that's, and your glucose might be a little bit more elevated. I don't think that's sufficient information to make the best correlations. So we know that for, I would say, it's hard to say whether for let's say a stage 4 tumor, an advanced metastatic tumor, whether just doing a therapeutic ketogenic diet would be enough to achieve like no evidence of disease long term or resolution of the tumor. I think that's quite difficult to ascertain from the data that we have. Of course, you have anecdotal reports of people that do long-term fasting and they get excellent results, but the long-term follow-up of these patients is difficult. And generally, as I said, I would consider the dietary ketogenic metabolic therapy as this metabolic priming baseline that allows you to more effectively use other treatments, including standard of care if necessary. So that's the next frontier. I mean, how do we successfully bring the diet drug combinations into clinical testing? In summary, I would say what we know for sure is to building from what we know about cancer metabolism at a fundamental level. So what are the fuel dependencies of cancer cells? We have substrate level phosphorylation dependency and OXPHOS insufficiency, and this makes cancer cells vulnerable to metabolic targeting. Then we built on top of this with preclinical studies, animal studies of the different diet drug combinations that we know right now that are very promising. And then what we have is all these clinical trials testing single interventions, but the next frontier is to bring it all together and combine in clinical research or in standard practice. Many of these things are available in standard practice too. Repurposed drugs any physician technically can use within the practice, and hyperbaric oxygen therapy also can be used. The real frontiers on the targeting of the metabolism, specifically using drugs. That is kind of where we need to go next. I'm just gonna give here like an overview of how to initiate perhaps dietary ketogenic metabolic therapy, and there's more information in the recently published paper. And I wanted this paper to be like it's called framework for a reason. It's intended to be like a framework of all the different references where people can go. It's not only what is in the paper, which is written more due to the nature of how you publish papers. It's written more for research, but if you read between the lines, you can find the recommendations and what other people have also done in clinical studies and even clinical trials especially for the dietary part. It's all there. And I don't like to be prescriptive on the internet. It's a little bit difficult to because I understand that what people would want is list by list, step by step paper or publication that would tell them, okay, I'm gonna eat 200 grams of broccoli and 50 grams of beef, and I'm gonna drink a lemon juice, and I'm gonna do a fast third day of the week. That's not That's not the proper language or the proper terminology that we would use in science. So I recommend I urge people to take all the time they need. Today we have many tools that large language models. We can ask questions to the paper also, and try to get some scientific literacy. So try to understand the concepts to build your own understanding of what you need to do. And of course, this also, I'm a big believer in patient autonomy. Perhaps I believe too strongly in patient autonomy, because I sometimes think that patients should have the freedom, because ultimately it's their life, and they should have the freedom to make the therapeutic decisions that they need to make. But it's not any patient. It is informed consent. So it's informed patients understanding and knowing enough about what to expect, for example, from standard of care, and this is different for each different type of tumor or prognosis that you might get, and you might take very different decisions depending on whether you are facing a glioblastoma or a metastatic advanced tumor versus whether it's a grade 1 or 2 tumor where standard of care and surgery, if it's a localized tumor, generally surgery can have very good outcomes. And then you could bring in dietary ketogenic metabolic therapy or some repurposed drugs or some of these things as perhaps as a prevention mechanism or together with standard of care to try to manage the situation. This is a little bit different from palliative care or diagnoses such as GBM, where we know unfortunately the standard of care doesn't have the best outcome. So there I feel more strongly that it is ultimately the patient's decision about what therapy they want to follow, and I would say try to learn as much as possible about the expected outcomes of standard of care, and then decide to bring in all the different tools from the toolkit, from the toolbox that you can or you want, including diet drug combinations. So I am a little bit more comfortable with dietary advice. I'm sure there will be some contrarians out there that you are not a nutritionist. Well, technically I am not, so I would recommend also working with a dietitian or a nutritionist that is at least a little bit knowledgeable in the applications of ketogenic diets, for example, from the epilepsy field or for the management of diabetes, and they can also help a little bit with the day-to-day questions that you might have about the food you should eat and these things. I want to remind that foods are not ketogenic, so there is no ketogenic food. Ketosis or nutritional ketosis or ketogenesis or ketogenic metabolism, this is a metabolic state of the body that can be achieved by fasting, by exercise, or by following a diet that is restricted in the amount of carbohydrates. That is ketosis. Foods by themselves are not there is no ketogenic property of the food that you will be eating, except to say, of course, that given that the metabolic state is defined by restriction of carbohydrate amounts, the foods that you will choose and select to eat will most likely be reduced in carbohydrate content. But this is one of the problems, that this field is not standardized. So even the nutritionists and the physicians, the MDs, the researchers that are working in the field, we mostly do this from kind of personal interest into this topic, and I do it, for example, from the study of cancer research metabolism itself. So it's difficult because there are no standardized guidelines for any of this. So basically, you need to be working with professionals or learn enough to do this on your own, especially on the dietary side. So with this disclaimer, long disclaimer, how would you initiate a ketogenic diet? Let's call it ketogenic diet with special focus on your levels of glucose and ketones, trying to achieve this state of fasting mimicking diet while you're still eating food. Because of course, the most effective way to achieve these effects is with water-only fasting, but this is a time-constrained intervention. You cannot be fasting forever. It's 100% caloric restriction. Eventually, you would go through your adipose tissue reserves or your fat tissue reserves, but eventually you would also lose muscle mass, and of course this is something we want to avoid. So first thing I would say you should do is to learn about macronutrients. So carbohydrates, protein, and fat, and you have to understand these concepts. So look at the labels of the food and just get a general idea. And there's hundreds and hundreds of food databases where you can learn about this. I included in the supplementary material of this recent paper, you will see a macronutrient calculator. So you can use that to calculate based on your height and your weight and your age. You can calculate your caloric needs, and it gives you also the macronutrients of carbohydrates, proteins, and fats that you should be eating. And then I would recommend using like a smartphone application, and there is many out there. I have no favorite. I would say use the one that's free and that is most effective and you like the most. MyFitnessPal, Chronometer, etc., etc. There is many applications that you can use to track basically everything you eat. So for the first week, I would say don't do any changes. You just calculate your macronutrients, and all you do is keep eating whatever you were eating, but you are tracking every single morsel of food that enters that touches your lips. You will be tracking, and you will be getting in this application. You will be getting the amounts of carbohydrates, protein, and fat that you are eating. So after you have this, keep in mind that there is also the Hawthorne effect, the observer effect. So just by doing this, you will probably start changing, but don't do it intentionally. Just track. So if you're tracking your macronutrients, whatever the number of carbohydrates that you will see after the first week, you could now aim to eat 0 grams of carbohydrates. I know technically ketosis is defined by carbohydrates under 50 grams or 40 grams, depending on the person, which should be enough to allow you to be in ketosis. However, I often find if people aim to 0, you will end up with eating like 10 to 20 grams of carbohydrates. Unfortunately, if you aim for 50, so if you try to be a little bit more flexible and you say, oh, I'm just gonna try to game the system, I'm gonna eat just on the edge. Typically what you'll find is that people end up being at 60 or 70 or 80 of grams of carbohydrate a day, and you will not enter ketosis. So your glucose might be much more stable, of course, because you are reducing most likely significantly the amount of carbohydrates that you eat, but the liver will not start producing as many ketones as you would need. So you are now aiming at 0 grams of carbohydrate, and this, without doing anything else, this should put you into nutritional ketosis, even if you don't adjust protein and fat. Of course, the selection of food that you will try to eat, if you are aiming for foods that have 0 grams of carbohydrate, these are mostly composed of protein and fat. You should try to pick some of the more fatty cuts of meat and fish, and you can also include some vegetables, some green leafy vegetables. So this should be enough to induce ketosis. Now, it will be important also during this transition period to supplement with magnesium and potassium and a little bit more salt in the food. So these are electrolytes, and this should help with, as you know, ketogenic diets, low carbohydrate diets have a diuretic effect, a loss of water weight in the body, which is often what people get so excited about when they start a ketogenic diet for weight loss. They lose a couple of kilograms immediately, and this is unfortunately, this is not losing fat mass, this is just losing water weight. But this can produce, some slight, lightheadedness or cramps in some people. So it's very important to supplement with electrolytes. And then after you are transitioning into nutritional ketosis, then you would adjust your protein intake. So you would try for your protein to be, typically you would start at 0.8 grams per kilogram, but it should settle in most people, it should settle in 0.8 grams per kilogram of body weight. And this is most likely not enough, so you will need to increase a little bit. In most people, it settles between 1.2 to 1.5 grams per kilogram of body weight of protein. And this is intended to maintain your muscle mass, your lean body mass. Keep in mind that, of course, if you're a person that does a lot of exercise, or if you are undergoing standard of care treatment, for example, chemotherapies, or some other therapy that's a little bit more aggressive or toxic, you might need to increase the amount of protein that you eat to sustain your muscle mass over time. And after this, you would adjust the fat content of diet to match your desired caloric intake. So if the idea is that you have some weight to lose, and you don't mind losing a little bit of fat tissue, then you can induce caloric restriction by modulating the fat intake. If you want to maintain your weight, you would go back to the calculation that you made in the beginning of your macronutrients, and if that's what you need to maintain your weight, theoretically, then you would adjust the fat intake to match your caloric intake. So you would have 0 grams of carbohydrates, protein adjusted to be sufficient to maintain your lean body mass over time, and fat content adjusted to whether you want to be eucaloric, so you want to maintain weight, you want to be hypercaloric even if you want to gain a little bit of weight. It's a little bit more difficult on a ketogenic diet, but it is possible technically if you eat what your body needs, enough protein and fat, you can even gain weight or muscle mass on a ketogenic diet. And if you want to reduce your calories and be in a caloric restriction state cyclically, you can also do that. And then, of course, you would also need to watch your micronutrient intake. So really, depending on how you organize it, I don't think it's, vitamin deficiencies or some of these things are very, very rare on a ketogenic diet, but you could supplement some essential vitamins, some micronutrients, the electrolytes, as we discussed. Some people supplement L-carnitine, and some people also like to supplement fiber just to have, if you are really aiming to have 0 grams of carbohydrates and you're not eating any plant matter, you can supplement insoluble fiber or soluble fiber, psyllium husk, or some of these components. All right, so now that you're doing all this, you still don't know whether, even though you are compliant with the dietary part, so you are aware and you are measuring all the food and you know about the micronutrients, you still don't know whether this actually has the intended biological effects, which is to induce nutritional ketosis and to mimic fasting while you're still eating, basically. So for this, you need to measure your glucose and your ketones. You can do this by finger prick measurement, for example, the Keto Mojo, or you can use these days also continuous glucose monitors or continuous keto monitors. They're on the market. There is a Freestyle Libre, for example, and I believe this one is already over the counter in Europe for a long time, but it's also being over the counter in the future here in the US. So this is just for now. Now optimization begins. So now you will be measuring your glucose and your ketone levels over time. How often kind of depends on the individual. I think most people feel comfortable measuring if you do finger prick in the morning, and then I would recommend in the afternoon before dinner, basically before the last meal of the day. That would be the most important time point, because that indicates that actually while you're still eating, you are maintaining a sufficient level of nutritional ketosis and you are inhibiting insulin signaling and growth signaling. As for blood work, I don't put that much emphasis on blood work, perhaps as others of my colleagues. I think it depends on the cancer diagnosis and on the status of the patients. For GBM, for brain tumors, there is you don't see that many blood work alterations, especially in the beginning after the diagnosis. But of course, if the situation gets a little bit more complicated, you might need to do more blood work. So for blood work, I just recommend basic hemogram, complete metabolic panel, liver and kidney function, and perhaps if you want like a high sensitivity C-reactive protein or some of these. Now, if there's tumor biomarkers available, you can also measure those protein tumor biomarkers. And I know there is a whole field of liquid biopsy and other more advanced screening techniques, diagnostic techniques. I think this is a personal choice. I personally would say don't invest all your energy into diagnostics if you are not investing also in the therapeutics. Like I wouldn't preferentially have as much information about the tumor as possible and then choose to do nothing about in terms of treatment. but yeah, this is something that each patient can expand upon depending on the situation. So beyond these more advanced also ways to see what the tumor is doing, ultimately I feel for most tumors what you will need is imaging techniques. So MRI, CT scans, or PET CT or PET MRI will ultimately determine whether the tumor is progressing or not. You can measure all the tumor biomarkers or liquid biopsies that you might want, but you ultimately you still need to have some visual confirmation whether all the therapies that you might choose to do are having the desired effect. Barriers to implement, I think they are, unfortunately, most of them are not coming really from the patients. I think if a patient if they understand why they are doing what they are doing, if they are informed, and if they are a little bit trained. The major barrier here, I think, is the training. So how to train well the patient to implement the dietary part, for sure. Most of the barriers come if the idea is to implement the whole dietary ketogenic metabolic therapy and the pharmacological ketogenic metabolic therapy together, the diet-drug combinations. This is where I feel we see a little bit more resistance. I think we are at the point where in most of the standard practice, when you bring up a ketogenic diet, depends on the physician, but they might say, well, yeah, you can do it. It's fine. It's really not either beneficial or not beneficial, but it's like a personal choice. When the idea is to also bring in repurposed drugs or other therapies such as hyperbaric therapy or the metabolic inhibitors, this is where I feel this still needs to be built more standardized, so we would have a higher acceptance across the whole medical field. And I understand. I have to say why this is a little bit discouraged in standard practice, because of the resources and the time that is necessary to dedicate to each single patient. Even if we're talking about the diet, to train a patient, this is unfortunately in the medical system. There is no department of metabolic oncology that you would have in the major cancer institutions where they would sit down with the physician and the nutritionist and the nurse and the assistants and try to steer the patient into how to implement all these therapies. So this, I feel, is the major barrier, is to bring some level of standardization and more documentation and more evidence on how to implement this in the standard practice for it to be applied universally as a new field of metabolic oncology that would be applied for all cancers in general. I think we are at the stage now where we are having a grassroots movements of people being interested in this, both the patients and also many physicians and researchers. This is a new field that is coming of metabolic oncology. But as we discussed, some of the definitions are not fully developed yet, and I feel bad sometimes. I think it's important for people to know exactly what they are requesting. For example, if you write a letter or an email to the NIH or the NCI or to your local congressman and you say, well, I want metabolic therapy, it needs to be explained what this means. So I would say this means to have N of 1 personalized oncology that is specifically focused on targeting cancer metabolism using diet-drug combinations and interactions individually for each patient as a single entity that is expanded upon and in discussion with the physician, basically to bring more flexibility and freedom into the clinical practice back for what it used to be, but right now everything is sort of constrained by very strict clinical guidelines, and there is defensive medicine where the physicians basically are afraid to do anything that's a little bit outside the guidelines, just for legal purposes. And you will see in the paper, I think, I like it has been framed as a debate, and I would encourage you to read also the peer review reports, where you can see some of the common criticisms that that colleagues from the field gave us to explain a little bit more and to expand of why we believe this is the future of oncology and why we believe this is the way therapeutics need to go in. So I encourage you to also read that, because if you bring this as a point of discussion to your own physicians, I think this would be also important for them to see, to get more information from there.